Hello, everyone. Thanks for joining us. I'm going to give us a few seconds to let everyone arrive. We've had some interesting sessions back to back, so I'm going to give people a minute to jump over. Okay. Thank you, everyone, for joining us. We're so excited to be continuing our conversations this afternoon on sepsis, this time from the newborn perspective with clinical nurse specialist Linda Lafrac. Linda, I will hand it over to you.
Okay, and good afternoon, everyone. Excited to be here and cover a topic very near and dear to my heart. And in terms of objectives, I'm going to just take a look and describe some of the changes in the incidence of early and late onset sepsis in the newborn. Review significant changes in management and identification that has occurred in the last couple of decades. Try to spend as much time on signs and symptoms of infection in preterm and term infant. Talk about the role of serial physical exams, and then talk at the end about the importance of laboratory testing to confirm whether or not what you observed is an infection. So what's changed in terms of infection in the newborn? Well, first of all, the Kaiser sepsis calculator, which I'm going to talk about in a little bit detail, was published. There have been a large number of national and state collaboratives that have focused on infection risk reduction. And those practice changes, often called care bundles, have made a big impact in the incidence of infection in newborns. Audits and tracking of all infections of infants in hospital settings has now become a standard. We now know that antibiotic exposure has been identified as a significant risk factor for all newborns, not only in terms of potential short-term adverse outcome, but certainly long-term adverse outcome. And we also know that antibiotic-resistant threats have increased over time. And then lastly, an additional step on this slide is that antibiotic stewardship programs have been mandated in hospital settings now for close to 20 years. And these mandates have really worked with staff to try and reduce unnecessary antibiotic exposure in the newborn. So the initiatives that have looked at improving antibiotic use, one is the fact that Jackie Spears back in 2006 made it a requirement in the state of California for hospitals to implement stewardship programs. We know Joint Commission and the Center for Medicare and Medicaid has made this a requirement as well. The Center for Disease Control publishes what's called an emerging resistance pattern report every several years. I'll show you an example of that. And there's been an enormous effort to educate the lay population about the risks of antibiotics so that they're not putting as much pressure on their medical providers with a better understanding of that this is something that comes with an adverse risk to their child. And then again, state and national collaboratives, not only to reduce antibiotic exposure, but also to improve practice. This is just a slide of what the Center for Disease Control report looks like in terms of emerging antibiotic resistance. And I think as I talk about all the strategies for monitoring babies, part of the reason it's so important is to make sure that we're not using antibiotics unnecessarily because of this emerging resistance. This report, I believe, was updated a couple of years ago. You can go onto the CDC website and look to see what the current threats are. So what are the risks of empiric antibiotic therapy? Well, clearly the one that I just mentioned, increased bacterial resistance, but we also know that antibiotic exposure in newborns alters the microbiome. And we've started to recognize more and more how important that microbiome contributes not only to immediate health, but potentially future disease risks in newborns, risks that we haven't fully identified yet. We also know that it does and almost always separates the infant from the mother, increases parental anxiety, increases the need for diagnostic and therapeutic procedures, and prolongs hospitalization and cost. So just to reiterate, empiric treatment means treatment given based on evidence without precise knowledge of the course or nature of the disorder, and we're going to talk about that some more. So what hasn't changed in newborn infection? Well, what hasn't changed is the clinical signs of an infection in a newborn remain nonspecific. What hasn't changed is the mortality and the morbidity related to either early or late onset sepsis remains considerable. Even though the incidence is dramatically reduced, the risk remains considerable. The primary pathogens in early onset sepsis have remained the same, herpes, strep, and E. coli. Pathogens in late onset sepsis are much more diverse. We'll talk about those in a little bit more detail, but as I mentioned, the incidence has decreased dramatically in the last 2 decades. Diagnostic challenges remain very significant in the newborn in that non-culture biomarkers are not reliably predictive for sepsis in the newborn. The differences again between early and late onset. Early onset occurs in the first week of life, and the organisms are related to maternal colonization and flora. Neonates at risk for early onset sepsis are managed in a variety of post-delivery settings, including couplet care, with what I have been told by some of my labor and delivery colleagues remains extremely challenging and difficult. Early onset sepsis at-risk infants who are being monitored by serial physical exams may not be in a setting where they're electronically monitored. It's all done manually. And the nurses doing that are from a variety of background, ranging from well baby postpartum to potentially a NICU nurse that's coming over to complete the exams. Late onset sepsis occurs later. Organisms are extremely variable, a mix of gram positives, gram negatives, and fungus, although fungal infections have decreased dramatically, probably because of the use of broad spectrum antibiotics has decreased and the use of prophylactic fluconazole during these courses. Late onset sepsis usually occurs in neonatal units with infants with underlying diseases such as prematurity and respiratory distress syndrome, making it extremely difficult to differentiate their symptoms of infection from their underlying medical conditions that put them in the neonatal unit to begin with. But they are monitored usually in a setting with continual monitoring, good lighting, and an experienced neonatal staff. So I want to talk about the Kaiser sepsis calculator for a few minutes. Up until this particular publication, babies at risk for early onset sepsis were managed using Center for Disease Control, ACOG, and AAP guidelines, but a lot of these guidelines for antibiotic prophylaxis algorithms and evaluation were based on data before there was widespread obstetric use of intrapartum antibiotic prophylaxis. And we know that early onset sepsis rates at that time were 5 to 10-fold higher than they are now. So what these guidelines resulted in were a very large percentage, 15 to 20% of term and late preterm infants being evaluated for sepsis, and between 5 and 8% being treated with empiric antibiotics. So this particular study was taken basically to examine the effects of neonatal early onset sepsis risk prediction models, and see how that affected sepsis evaluations and antibiotic use. And this was done in a large integrated health system, specifically Northern California Kaisers. It involved over 200,000 babies, and the study period was divided into 3 separate subgroups and occurred between 2010 and 2015. The first group, which was almost a 2-year group of statistics, was basically managing these babies using national guidelines. The second group, which they call the learning period, which was about 18 months, used a multivariable estimate of sepsis risk at birth. And the last period used this risk estimate combined with the infant's clinical condition during the first 24 hours of life. So what were their main outcomes and measures? Well, the primary outcome was the administration of antibiotics in the first 24 hours. And the secondary outcome was the use of blood cultures, antibiotic administration, on clinical outcomes, including readmissions for early onset sepsis. And what they found in their study was they were able to reduce the use of blood cultures in babies. Babies had way fewer blood cultures done in the final stage than in the first two stages. That empiric antibiotic administration in the first 24 hours was halved. The incidence of confirmed early onset sepsis was similar in all three periods, and you can see how low it was. 0.2% in the learning period, 0.2% in my slide. I'm having trouble seeing the whole slide because of this black box. All right, but anyway, very low in all three periods, and much lower than it was a decade ago. Readmissions for early onset sepsis, meaning within the first 7 days of birth, were rare. 5.2 during the baseline period per 100,000 births, and during the phase of using the calculator and physical exam, 5.3 per 100,000 births. I think one of the most important parts of this paper was talking about when these infants presented and what symptoms they presented with in the first 24 hours. If you could look at the graph on the right, you see that about 90% of them presented with physical signs of infection within the first 24 hours of life. The most common symptoms were apnea, tachypnea, respiratory distress with either grunting, flaring, or retracting, pallor, poor perfusion, vital sign instability, and hypoglycemia. So again, if you look at when these increased clinical exams need to occur, basically these babies are going to present pretty quickly after birth in the first 24 to 48 hours. And in terms of the babies that actually had early onset sepsis, 6 of them were actually symptomatic at birth. 4 were well appearing, but then developed signs of infection between 5 and 24 hours of life, and those babies were identified based on clinical exam. This is what the calculator looks like. You simply input gestational age, highest maternal antepartum temperature, and you can see the rest of the categories, and then hit the calculation button. You also then factor in physical exam whether we were either well appearing at birth, equivocal, or had signs of clinical illness. And then this gives you a risk score. This is just a more comprehensive list of signs of early onset sepsis. This is from the World Health Organization. I particularly like the severe chest indrawings, otherwise called retracting. But again, the major categories are changes, abnormal findings in the respiratory system, circulation with poor perfusion, the GI tract with poor feeding or distension, general overall with pallor, temperature instability, or neurologic signs. A year after the sepsis calculator was published, the American Academy of Pediatrics Committee on Fetus and Newborn Committee on Infectious Disease published this article, which supported the use of the calculator and basically changed the guideline in terms of creating this clinical practice. And I wish I could get rid of it. Hang on, I'm going to get rid of this black thing at the top of my screen. So I can read it. Oh, anyway, this particular article, again, published by the Academy, and you can see here that the second author is Bill Bennett of Stanford faculty, long-standing icon of infection expertise, and Karen Popolo, who was originally one of the authors on the Kaiser sepsis calculator. So big changes. Just a quick word about early onset sepsis in the non-late preterm and term infant. The preterm infant is a very different category in terms of risk. The organisms are the same in early onset sepsis and preterm infants, but it significantly impacts length of stay, significantly impacts survival, and survival without morbidity is also significantly impacted. And I think it's an important piece to remember when you're looking at term versus preterm infants. A little bit about the use of serial physical exams in these patient populations. This was an early study about serial physical exams that was published out of Italy in 2013. They did prospective sequential studies over 2 12-month periods. The first period, all the infants had blood work as well as standard physical exams. And period 2, they dropped the blood work and all the babies simply had a standard physical exam done at standard intervals. And the results were that the interval between signs of sepsis and starting antibiotics was no different when they dropped the use of obtaining labs. Colonization rates were comparable in the 2 groups, and there were significantly fewer babies that were exposed to antibiotics. The second article on serial physical exam, again out of Italy, was a retrospective cohort study done at a level 3 birthing center, again looking at whether serial physical exam was a safe tool for managing babies at risk for early onset sepsis. There was a standardized form developed. Bedside nurses and physicians did these exams that detailed well-being, skin color, and vital signs. They were done actually quite frequently. You can see 3, 6, 12, 18, 32, and 48 hours. They looked at rates of sepsis workups, how many received empiric antibiotics, and what outcomes they had. During this study period, they only had 1 case of early onset sepsis with H. flu for a rate of less than 0.5 per 1,000 deliveries. Their conclusion were serial physical exams reduced the need for unnecessary lab work, and there were no adverse outcomes. And then this is the most recent article. This was another article. It was a quality improvement framework looking at serial physical exams done 24 to 48 hours for infants that were suspected of or described to be at risk for early onset sepsis. These babies, however, were followed in the NICU, so they had the benefit of electronic monitoring and much higher nurse-patient ratios. The safety outcomes were that there were fewer babies exposed to antibiotics. The antibiotic days were shorter. There were no adverse results. This was 17,000 babies and significant improvement in antibiotic exposure. And their conclusion was that serial physical exams to guide empiric antibiotic therapy in neonates expected of early onset sepsis have the burden and did not delay treatment of infected infants. So certainly a strategy that has been shown to reduce the risk of antibiotic exposure and not delay any treatment or increased incidence of missing babies. So summary for early onset sepsis is that infants born in greater than 35 weeks can be stratified to a level of risk. There are algorithms available for that. Serial physical exams have been used now for well over a decade to detect the presence of clinical signs after birth, reducing the necessity of initial labs. But it does point out in the summary that each birthing center needs to put together a locally tailored document and guideline based on your physical assessment or your physical facility, what kinds of spaces you have to examine these babies, what your staff mix is. So there's not one protocol that fits all. They do recommend standardization. These exams and the frequency of doing them can be put into your electronic medical records and can assist with the assessment guidelines, the recommended intervals based on initial risk. I'm going to switch gears here to late onset sepsis. As I mentioned, the organisms are quite diverse. Years ago, when Children's Oakland joined the Vermont Oxford Neonatal Collaborative, our very first practice improvement 2-year project was to reduce bacterial infections in our unit. And one of the things we did was we collected data over about a 3-year period just to see what kinds of organisms we were having, what the descriptors were of the patients. So this is just a list of some of the organisms during that 3-year, again, which is prospective, descriptive. We did quantitate what we saw as presenting symptoms, and the two most common in the late onset sepsis group were increase in oxygen or ventilator support, almost 50% of the babies, a change in gastrointestinal function in 42% of the babies. About a quarter of them had a fever as the presenting symptom. Increased apnea and bradycardia, you can see, was about 15%. Lethargy, 13%. And then there was a variety of lots of other signs and symptoms, including hypothermia, low blood pressure, elevated blood sugar, poor perfusion. But the most common symptom in our preterm babies had to do with a respiratory deterioration, a change in the need for support, or an increase in the severity or frequency of apnea and bradycardia. And our most common presenting symptom in our term infants was a fever spike. And this, again, was a 3-year period. It represented over 100 patients. And I have to say that these were patients with positive blood cultures, not necessarily confirmed to be true infections, because we had a lot of sorting to do with our improving our diagnostic accuracy back in the early 2000s. This is just a recent study coming out of Israel looking at late onset sepsis in a neonatal setting. They were looking at risk factors in 4 study periods of which babies within their setting developed sepsis. And this was done over many years of investigation. It involved over 30,000 infants. A shocking 23.5% of them had late onset sepsis. Looking at who were those patients, these were patients that were less than 27 weeks. And it's quite clear that the more immature you are, the higher you are at risk for sepsis, because of a variety of reasons. One is that you're sick and you're probably instrumented. And 2 is because the more immature you are, the less effective your immune system is. Any baby that had had a delivery room resuscitation was at much higher risk for late onset sepsis. What I found interesting about this paper was that they reported the rates of late onset sepsis. So in the study period from 1995 to 2000, the rates were almost 30%. And in the next study period, they were down to 13%. And now in most settings throughout, certainly throughout the United States, that the rates of late onset sepsis are significantly below this. So late onset sepsis rates have decreased in the past decade, again, because of practice changes, but also because of improved diagnostic practices. Organisms vary, risk increases with decreased gestation, diagnosis remains difficult because of non-specific presentations. So how do you teach staff to recognize an infection in a newborn? Well, I think you've got to educate them about what's happening in their own clinical setting, including what are your infection rates, what kinds of organisms are you seeing, what are the outcomes of those babies that develop infection. This can be done in staff meeting presentations. This can be done in written documents. I think it as many ways to share it is important. I think sharing antibiograms with staff is important, and this is simply microbiology data that shows what organisms are being isolated in your setting, what the sensitivity patterns are, how those are changing over time. I think most importantly is a drill down of each infant who does become infected to share with the staff what the presenting symptoms were. So this has become a low incidence and yet high consequence problem. So they're not going to see a lot of cases, which is the good news. And the hard part is then how do you teach staff to recognize these babies. So I used to do drill downs of each baby who had a positive blood culture. This is just an example of one, and present them at every staff meeting. I'm going to move forward a little quickly because I want to make sure and cover the diagnostic piece, and I'm down to my last few minutes. I want to just throw this out there. This is a quote by Joe Schulman, who was part of our expert panel on our antibiotic stewardship research project that we did a couple of years ago. And he's been saying this for a long time. When we work with units who have very different antibiotic exposure data, we worry that but anyway, you can read this. We often devote insufficient effort to exploring differential diagnosis because the underpathophysiology resolves, meaning the baby looked bad. There were some bad physical signs. We started antibiotics, the baby got better. But if we rule out sepsis, we should rule in conditions that explained what the baby's problems were. And I'm going to skip over this as well. So I want to end up talking about this antibiotic stewardship project that we did here in the state of California. Started in 2021, and we had a sustaining year through 2022, and we wrapped up with our last meeting at the beginning of 2023. And this project included an expert panel of neonatologists, of infectious disease experts, pharmacists. I was the only nurse, but nurse, and we looked at case-based guided learning where we had these units present cases to us so that we could help them with differentiating what was a false positive and a true infection. And what we discovered over time is that many units did not trust their blood culture results. And as I mentioned, there's no non-culture biomarker that is definitive in diagnosing an infection in a newborn. But we had units that were reporting blood cultures that were positive that they didn't believe because they were odd organisms. It didn't make any sense. The baby looked good. And then we had more units not believing a negative culture, calling it culture negative sepsis. And so we realized that this not being able to trust your blood culture results was really resulting in a huge, what we saw as something that could be used to reduce unnecessary antibiotic exposure. So we took a look at a couple of things. We started out by doing a literature review to see what was the evidence-based practice on how to obtain a blood culture in a newborn. There's certainly some guidelines out there, but none of them were very comprehensive. We presented these evidence-based findings to our participants, which were, as I mentioned, 29 units throughout the state. 28 of them participated in our study, so we could take a look at evidence-based practices and then see how many of our units were using those evidence-based practices in their own setting. So just to reiterate, clinical confidence in the reliability of a blood culture is so critical to the appropriate diagnosis and management of sepsis in the newborn because biomarkers are not reliably predictive. So we published our findings in the Infection Control and Hospital Epidemiology Journal in February of last year. The big issues had to do with contamination. So we looked at the main issues that would contaminate a blood culture. Poor technique was at the top of the list, where we had a fair number of units that reported that when they observed people drawing the sample, that they were using poor technique. Insufficient skin disinfection was the second highest. Collection through an indwelling device, which is also something that if you've got a critically ill, very low birth weight patient, sometimes the only place you can get your samples through an indwelling device, and we know that those devices can be colonized. And then we used to always tell the nurses to use the same needle to inoculate the bottle as they drew the sample with because of the risk of HIV, but we have recent evidence to show that you can decrease false positives if you change the needle for the bottle inoculation. All this is described in this comprehensive reference that I have at the bottom, which is from Clinical Microbiology Reviews. The most common reason for false negative is inadequate volume. And there have been a number of studies that have looked at weighing samples when they get to the microbiology department, showing that even though we know that 1 ml is the recommended volume for a neonatal blood culture, that there are many bottles that arrive with less than that. So looking at ways to improve adequate sample size. I'm gonna skip over this. So How do we improve accuracy of blood cultures to determine that if what we saw with what we observed was indeed a true sepsis, is to standardize, educate, and monitor for competency, create a blood culture competency. Skin asepsis should always include chlorhexidine chloride, and the most recent Shea White paper supports this even in patients that are very low birth weight and less than 6 weeks of age. Make sure that a minimum of 1 ml is drawn in the sample, and then document everything on the sample and in the medical record. So our job as care providers is to make objective clinical observations for signs of infection and thoroughly evaluate all our contributing factors. And this can be done through standardized forms and procedures and education, and make sure that when we are confirming whether this is truly an infection, to obtain a blood culture using evidence-based practices. We know that diagnosis remains difficult. Treatment is usually based on risk and clinical exam. Broad spectrum coverage is going to be something that's not going away because of the complicated nature of this and the risk of missing this in our high-risk patients. But we know that most organisms grow by 36 hours, and if we've had an adequate sample, we can stop the antibiotics at 36 hours. Anyone that would like to look at all the work that was done, you can find this on the CPQCC website, including articles, lectures, and everything we did related to improving blood culture positivity. So I'm gonna stop now because I'm over time. But I think vigilant physical exams and assessment will continue to be a foundation for early recognition. And staff education should always include case reviews to improve staff awareness in their own clinical settings. Okay.
Krista, Linda, that was wonderful. You actually do have a good few more minutes if you do want to go back and do any of your extra slides. You have until
actually
4 o'clock.
Linda, if you could you go back to slide 27? And we'd love you to clarify about what you mean by abnormal GI symptoms.
Slide 27.
We think it's 27. Oops.
Yep, it's that one.
Oh, okay. So abnormal GI function was whether these were babies that developed, if they were being tube fed, they had residuals, increased residuals. They had sometimes have bilious residuals. They had emesis, they had distension, they had diarrhea. So something that was different from baseline. In the bigger babies, we saw vomiting. In the littler babies, we often saw just distension and gastric residuals. Just to make it clear, this is a group of babies who were in a level, what we call ourselves a level 4 ECMO cooling center, and an enormous number of our patients had a primary surgical diagnosis, whether they were term or preterm. But these were the symptoms we saw in the 3 years that we collected data on presenting symptoms. And now that I had my watch set and everything, and I still did it wrong.
It's all good. It's all good. Dr. Gibbs?
Now that I've got a minute, let me go back to, I just wanted to mention something about common signs in older infants, because for nurses that work in neonatal units, there are often babies that are there for many, many weeks, whether they were born prematurely or they have some complicated congenital anomaly. And these were signs that we identified in our older infant population in the NICU. Changes in temperament, for brand new born babies, no one knows what their temperament is yet, so it's hard to figure out if it's a change. Feeding changes, babies that were too sleepy to nurse or bottle feed. Unusual irritability, pale or mottled, that when people always talk about doesn't look right, but as a clinical specialist, as I rounded, if a nurse said to me, this patient doesn't look right, that spoke volumes to me. And then we started looking at some of the more objective findings like blood pressure and perfusion, diarrhea and vomiting, fever, or subnormal temperature. So these are some of the things you see in older infants. Let me go back to my slide. that I flipped through. I wanted to just make it clear, I think many of you know this, but the systems used for recovering organisms in samples sent for blood culture, the BACTEC system has been around for many, many, many years. And this is a system that can detect very low colony forming units of bacteria. And this is just one of many studies. This was specifically done with a known inoculate. This is group B strep. I like to still call it group B strep. A known inoculate of between 1 and 10 colony forming units per ml. And they use different volumes, a quarter of an ml, a half of an ml, and an ml. And if they if they put an ml in the system, every single bottle recovered this organism reliably, even though these were extremely low colony forming unit inoculates. So this has been shown many times. This is one of many studies that has helped support using 1 ml of blood for a neonatal blood culture. So I just wanted to reiterate that. There's no reason not to trust a blood culture if it's been obtained using evidence-based practice, good technique, 1 ml minimally. And then just in summary, early and late onset sepsis incidence has decreased dramatically because of all the practice changes we've made, either in terms of reducing risk of infection based on just practice changes, and also we're doing better with our diagnostic workups. We were not doing that well for many, many years because we didn't standardize, we didn't monitor how well the sample was obtained. Many microbiology departments have reports of contamination reports that you can take a look at. Sometimes they're for the entire hospital, but we got these reports in our NICU and we followed up. If we had a baby with a positive blood culture who was then, it was determined with an interdisciplinary review that this was a contaminant, we followed up one-on-one with the person who drew that sample to see if we could figure out a way, if there was any educational deficit needed to be dealt with. We know that the mortality and the morbidity of these two infections, early and late onset, are significant. And that's why so many people use empiric antibiotics, and that's not going to go away. We know signs and symptoms are nonspecific. I was so interested in Dr. Gibbs talking about nonspecific symptoms in mothers because I never thought about that, but certainly in babies they are. I mean, these can be associated with birth transition or their underlying condition or something iatrogenic, like the probe in the incubator fell off and the baby's got a temperature of 38.4, but it's not because the baby's febrile, it's because the probe's trying to heat up the sheet, the mattress. Staff education and vigilant physical exams, these are never going to go away. These are critical to ongoing picking up infection in the newborn.
Thank you, Linda. It's Christine. I'm going to ask you to stop your slide deck. I want to welcome back Dr. Ron Gibbs. And we're very grateful that he's joined us again. And we're going to do kind of a team Q&A here. And hopefully she'll get it there and then folks can see. Folks are just seeing who's speaking. So I'm going to try and stop talking. Ron, do you have any comments? I mean, you just saw some of a, really good presentation. Is there anything you'd like to comment on first?
Oh, just very interesting parallels in needs for recognition, non-specific signs, and need for education throughout.
We have a question here, and this will go to Ron. Is there any link in maternal fecal contamination during pushing that may lead to late onset neonatal sepsis? Actually, it's a question for either of you or both of you.
Well, for early onset disease, that is, I'll defer to Linda, but that's certainly linked with obstetrical risk factors. chorioamnionitis, prolonged rupture of the membranes, early gestational age. And there are organisms of the maternal genital tract, which obviously cause ascending infection in the mother and are leading causes of organisms in early onset sepsis. Linda just mentioned Group E streptococci, for instance. It's more vaginal source than fecal, and prolonged pushing and fecal contamination doesn't seem to be as important as lower genital tract. Linda, your thoughts?
No, I would agree with that. Don't think we've seen a difference in that with prolonged pushing.
The question, you know, kind of came through because folks are wondering, there was a comment there that, you know, perhaps during pushing, that we are not as attentive to what's going on with the pushing and where bodily fluids are and things like this. So, but thank you for that. I want to ask you, I'm going to go to this one here, Dr. Gibbs. The stats on antibiotic delays. 8% mortality if administered within 1 hour. Someone wants to know which hour. That's within 1 hour of what?
1 hour of diagnosis of sepsis.
Of diagnosis of sepsis. 8% mortality?
In pregnant women, yes.
Oh my gosh. Okay, thank you. That's very intense. Someone was commenting, Ron, about seeing that blood cultures are not obtained prior to starting the antibiotics in the flow sheet. Is that going to be updated?
It's clearly in the text. You know, there's just so much you can get into a flow sheet and still make it manageable. But in the text, it clearly says get blood cultures, get cultures from the anticipated source of the infection. And there's value in getting blood cultures even if the antibiotics have been started.
Got it. I mean, this is kind of a combo question again. Do you feel that there are often misunderstandings between the specific and non-specific signs for both the birthing parent and baby? For nurses who often work with both, how can we best educate and distinguish these for best learning and recognition?
Linda, do you want to start with the?
That's such a rough one. I think these non-specific signs are not going to go away, especially in these early onset babies. When you're talking about a 34-weeker that might have been delivered by C-section and is transitioning and is breathing a little fast, maybe somebody didn't wrap them really well and their temperature is low. I don't think that's going to go away. I think that what's important is this case review, where if you have either a child who definitely has proven infection, that you review those presenting symptoms with your staff on a regular basis so that they can learn from these infrequent cases. And then if they are culture negative, presuming that an impeccable blood culture has been obtained, which is very doable, that then you go back and you just take a look at, okay, what were those symptoms and what can we attribute them to? Like Joe Schulman is always saying, we rule out sepsis all the time. We don't necessarily rule out what happened with this baby that we had these problems. One of the things that nurses used to tell me all the time is my patient's having a lot of increased apnea and bradycardia, but I had a very vigilant new intern on last night who was just determined to wean the ventilator support. And I think it just, you know, there was some pulmonary collapse and this baby had this because of the weaning process. Not that it wasn't done for all the right reasons, but it was just overdone. So we had a baby with respiratory deterioration from aggressive CPAP weaning, not from infection. And those are important things to talk about.
Yeah.
Christina,
yeah.
could I just go back? I wanted to add
Of
one
course.
other comment about the blood cultures. So a positive blood culture is not required for the diagnosis of sepsis.
In
It's a-
mothers. Yeah,
In
well,
mothers, right.
Yeah.
It's the call of an infection scenario with infection severe enough to cause end organ injury. Many of the patients, many of the women will have positive blood cultures, and not everybody who has a positive blood culture will have a diagnosis of sepsis. So I wanted to make that.
Could you discuss, Ron, the box that addresses the low MAP, specifically about what treatment should be added to antibiotics and fluid resuscitation?
So if the mean arterial blood pressure is low, optimize the fluid intake, get the antibiotics on board, and I think escalation of care. In obstetric units, we're just not used to seeing patients with sepsis that often. It's just not that frequent. And getting a rapid response team that can do measures assessing cardiovascular status, urine output, leg raising tests, and so on, and get that team on board.
You know, there is an emphasis in these questions, and I'm trying to organize them in my mind in terms of postpartum, post-discharge. So a comment question combo came in about, you know, parents, new parents, birthing persons who have been discharged now, about showing up in the emergency department. And, you know, there's lots going on in this space, meaning CMQCC, others are identifying the need, right? And have for years, actually, to bring in those that work in the emergency room, to communicate with them and standardize processes with them. So how do you feel about patients bringing, you know, a form with instructions or whatever, you know, with them, having that be prepared to go to the ED or the clinic with them?
Yeah, well, the point of contact almost always is going to be the obstetric care provider. And the obstetric care provider may say, get to the emergency room, I'm going to call them, or I will meet you there. That'd be even better. Or it may be someone who is far from the delivering hospital. Well, then a call to the ED and say, this is Ms. Smith, and she had these risk factors or she didn't, but I'm worried about her having sepsis, and make that call. I think that's awfully important. The other problem with short hospital stays, and half of the cases, is that we have to have the family or the care providers or the support team aware of what to look out for. And that was the purpose of many of the tools that we showed. Shortness of breath, fatigue, not being able to get out of bed. And then there is a need for advocacy. If you call and speak to the nurse in your doctor's office and you're not getting the kind of response that you think you need, then it's a point of saying, I really want to be seen. I'm worried that I have sepsis. This is not just normal.
Ron, I'm going to go out on a bit of a limb and say, actually, I think there are many women, many birthing persons who their first point of contact is the ER. And it isn't their obstetrician, midwife, nurse practitioner that's devoted to maternal child obstetrical care. So I think we find, you know, that we really do, you know, need to pursue more and more of this with emergency rooms. And we know that for preeclampsia. We know that for hemorrhage, right? And preparing patients to be able to give some sort of history upon presentation, or guiding them, whether it's with papers or whatever, to prepare them for that. And go ahead.
Yeah, so, right. So our intent is to get the word out about problems of diagnosis of sepsis and delay, not just to the obstetric care providers, but to emergency room physicians and other points of intake where they're probably not going to see that many obstetric patients. And it was surprising to me in the work we just published this month that 20% of the cases of sepsis came to hospitals that did not have a labor and delivery unit.
There you go, right?
Yeah, there you go.
And yeah, and then we get into the whole, how far are you? And, you know, that entire conversation. I want to focus again on the discharge, just like you started with, Ron, with a push to discharge mom baby 24 hours after vaginal birth, even with GBS positive moms with no antibiotics. Is there some sort of room for a recommendation for newborns being seen in the clinic sooner or in the outpatient area? Any thoughts, either one of you?
No, that'd be for Linda.
Well, I guess I would be really surprised. So this is a baby whose mom is GBS positive who received all the appropriate antibiotic prophylaxis at the appropriate time, or?
So according to this question, after vaginal birth, even with GPS moms with no antibiotics.
So I don't think that makes any
More.
sense. I mean, that if you put that baby in the sepsis calculator, they would not have a great number. So that makes no sense to me. I mean, I'm guessing there's probably some L&D nurses who might be able to speak to that, or obstetricians, but that seems contrary to what would be safe for those babies to be looked at in that first 24-hour period with a serial physical exam based on a risk.
Good. Thank you. Thank you. I want to go now to a question that came in a little bit earlier, and that is, Linda, what do you, wondering if you've already reviewed this, what do you say about culture negative sepsis for babies? I mean, Ron's kind of touched on it again for moms.
Well, I mean, we can have a newborn with a blood culture that's negative, and that baby can have another etiology for the sepsis. It can be a pulmonary. Obviously, if we're concerned about meningitis, there's a spinal tap done. Most of the babies that we end up calling septic do have an organism in their blood. And culture negative sepsis, even though the term is still used, is a term we're trying to actually kind of move away from in terms of understanding how reliable the back-text system is, and that if the sample is an appropriate volume, even if the mother's received antibiotics during delivery, that baby's going to have an organism grow from their blood if it's in there. And if it didn't grow, then they're not septic. That's been one of the most difficult things to overcome in terms of stewardship programs. Anyone who's been practicing for more than 20 years and has watched a few babies die of sepsis, it's a very scary thing to not believe the blood. I mean, if the blood culture comes back negative and you saw the baby and the baby looked bad, I don't think we're going to get away from that completely, but that term is one that upsets me because I think it's extremely rare. If the sample is done using evidence-based technique, you're going to get an answer. You're not going to have a negative sample and a sick baby. Obviously,
go ahead. Go ahead.
We're just pushing people to take a very deep dive look at, okay, so what did you see and what else could be causing this besides infection? Don't just always go to, oh, well, that baby was infected. What else could be contributing to those symptoms that you saw that concerned you?
And, it's coming in on it's more of a chat, Linda, but people are commenting about that infant we were hypothesizing about earlier, that they are having them stay. Some says they stay for 48 hours.
Right.
And yeah, yeah,
It's great, because if you look at the sepsis calculator data, those babies started to not look right by 48 hours, most of them by
Yeah.
24. So that is really the safest practice.
yeah. Very interesting question that I haven't thought about. We got a couple minutes left, Ron. Are some, I have not heard this, and folks, Molly, whoever you are, you found the right person with Dr. Gibbs, because he's an expert in multiple areas of infectious disease. So Dr. Gibbs, are some facilities routinely giving antibiotics for 3rd and 4th degree tears?
Yeah, so it's the next to last slide that we showed, and we don't
Okay.
have to bother to bring it up. But I would refer you to the bundle on sepsis that we published last September. And in there is box 2, which are evidence-based indications for peripartum antibiotics, and 3rd and 4th degree lacerations are one of the indications.
Got it. Got it. Okay. All right. And then I think I've got one question here, and it's to kind of end. And again, it's kind of the full continuum of care, and realizing how many people are involved with caring for folks. Because this came in from a nurse doing home visits for postpartum clients. And she just says that, this is the first time that she's heard about the sepsis screening tool, and she's very interested in looking at it, whether in the slides or at CMQCC. But it's her first time she's seen this in a detailed way, and she wants that awareness to hit that group of folks. And because they can sense something's wrong, but they're not always sure, especially when they're giving their SBAR, their report off to somebody, correct? So, they really appreciate these resources in order to share, around the team. And I want to let you know, as a last note on this connection to postpartum and antepartum and pre-pregnancy, the state of California is looking at the full continuum of care for pre-pregnant, pregnant, and post-pregnant persons and their newborns. And what that will look like, we're not sure, but we're happy to say that CMQCC, DHCS, Department of Public Health are looking at this, and we're happy to be a part of that. So we really appreciate it. So I want to thank Dr. Gibbs and Ms. Lefrak for joining us today, and for being so generous with their time and with their decks and sharing just wonderful information. So thank you to you both. And then I want to say thank you to everyone out there.